My name is Brandon Olivieri. I'm going to be talking to you about tibial CTOs. These are my disclosures. So the first thing I wanted to talk about was that CLI really takes a team to treat appropriately. The revascularization specialist is really only a small part, and honestly, treating CLI from a team approach from a multidisciplinary standpoint has actually been shown to improve limb salvage rates in studies. At the center of the patient team is really the patient. If you think about it, most wound healing actually occurs outside of the medical office or the medical facility at the patient's home when they're by themselves. So unless you really have the patient educated and empowered to treat this disease, you're going to have a tough time healing the wound. We know that critical limb ischemia carries with it up to a 25% mortality rate at 1 year and 50% mortality at 5 years. And this is mostly from cardiovascular disease related death. So in my practice, it's really helped me to improve my interventional success by getting cardiac clearance ahead of time. This doesn't just help in the peri-procedural area, but in the long term with optimization of cardiovascular risk factors, which ultimately lead to MI and strokes in these patients. This is just a case example. We have an 83-year-old male with multiple cardiovascular risk factors who presented with a necrotic left posterior heel wound. It was on the verge of wet gangrene, as you can see. He also had intractable rest pain, and the family begged for urgent intervention. You can see his initial angiogram shows that after that stent, he has occlusion of his P1/P2 popliteal with severe calcified disease there. There's an occlusion of the tibioperineal trunk as well as the anterior tibial artery. And so we approach this in a typical fashion, antegrade access. We're able to get down across the occlusion in the popliteal and into the anterior tibial artery. You can see there in the injection. Then there's a flush occlusion of the tibioperineal trunk. And to actually approach this, got retrograde posterior tibial access. You can see the catheter here, injecting from the catheter here to try to rebuild that bifurcation of the tibioperineal trunk. And ultimately was able to cross, had to stent across the popliteal, unfortunately, because of this severely calcified disease, but ultimately, had 3-vessel runoff and his pain resolved. However, despite all that work, it wasn't even a very long case. The patient had an MI 3 days later and died. So this really just to drive home the point that, cardiovascular disease is really what's gonna kill these patients. So it's very important to get them stratified and worked up appropriately. I find that in these procedures, they can be really long. They can take a lot of resources. So planning is extremely important ahead of time. These really should be targeted strike missions. Honestly, with every procedure that we do, it should be a targeted strike mission to kind of get in, fix the problem, and get out. So I find setting a defined goal for your procedural outcome, for example, establishing flow to the angiographism of the wound bed, visualizing literally a step-by-step procedural plan, knowing every single wire you're going to use, every single sheath, every single balloon, and having bailout strategies in case you cannot cross. And also, honestly, knowing when to stop. It can be difficult to get caught in the weeds in these procedures. They're quite long, and there's a lot of disease usually, so you have to know when to get out because these are sick patients. One thing that really gets into procedural planning is that cross-sectional imaging really just is not efficient or is not optimal in visualizing the vessels we need to open. We know that nowadays we know that most CLI cases we may have to go into the foot, and basically getting a diagnostic angiogram ahead of time reduces the amount of contrast that you use for a procedure, allows you to classify the plaque and the occlusion, and may give you, an advantage in actually crossing lesions. And this is kind of what led to this recommendation by the CLI Global Society to really get a diagnostic angiogram in these cases. Really helps with planning. As far as access is concerned, you can use retrograde access. However, I find that in a lot of cases, because we're going to the foot, you not only run out of device length, catheter length, wire length, but also you have reduced pushability, torqueability, maneuverability, because the vector of force is directed up the aorta rather than down the leg. So you really lose a lot there. Whereas for antegrade access, you really gain a lot of length. You're able to go around the pedal loop for the most part, in pretty much every case. And you get pushability, torqueability, maneuverability, because again, your vector of force is directed down the leg. And we usually get access, obviously, under ultrasound. This is kind of how we would view access. We get access in an axial plane, but once our wire's in, the wire tends to go into the profunda because it's deep. But if you put a little curve on the wire and turn your probe sagittally, you can navigate under live ultrasound into the SFA. And this is very helpful even for flush SFA occlusions because you can see the SFA right there. In every single critical ischemia revascularization case, we prep the foot and have a low threshold to, get pedal access, even as a primary approach, depending on the CTOP classification, which is what I'm going to talk about right now. Now, this has really kind of changed how we treat critical ischemia and approach these cases. It's extremely helpful. It was developed by Jihad Mustafa and Fadi Saab, and it basically is a technique to approach these lesions in terms of keeping your wire intraluminal. And going subintimal in these cases is not the end of the world. You can always re-enter, but staying true lumen can save you a lot of time if you can't re-enter easily. And basically by looking at the convexity and concavity of the plaque, you can determine which with higher likelihood of where your wire will stay. For example, here you're going to stay intraluminal. Here at the end of the occlusion, you basically may be driven subintimally. So this is kind of a great way to look at these cases. The other thing when looking at occlusions is that not all occlusions are the same. You can see long segment, what look like long segment chronic total occlusions, and they may be just a few focal occlusions with hibernating lumen in between, which is just not opacifying. So, in end-stage renal disease patients, you may get these columns of calcium, which are really hard to cross. But in a lot of patients, there are just focal occlusions, which once you cross them, your wire just flies through. So I encourage you to at least try with even the most daunting occlusions, because you'll find that you will get across easier than you think. Here's just an example of that. It's an 80-year-old male with multiple cardiovascular risk factors. He has gangrene of his left fifth and fourth toes. The family, again, adamantly refusing against amputation. So you can see here a diagnostic angiogram. There's a flush occlusion of the superficial femoral artery and really not much reconstitution at the level of the popliteal artery. There is some hint of infrapopliteal vasculature, and there's a hint of the posterior tibial opacifying here. So it seems like there's a very, very long occlusion from the SFA down into the tibial vessels, which could be daunting. But again, like I said, if you go for these cases, you'll find that a lot of the time they're not as daunting as you think. So here we got antegrade access. This is another technique. If you can't redirect your wire into the SFA under ultrasound, you can take your profunda access, put a stiff support wire down as a safety wire, pull your sheath back and inject, and then navigate, usually an 018 wire, could be a V18 or just the access wire from a micropuncture sheath into the SFA under live fluoro. That's another way to get antegrade access if your wire goes into the wrong location. So here was able to cross the SFA into the popliteal vessels. You could see even from injection here that what we thought was a completely occluded trifurcation, now we can see that at least the tibioperitoneal trunk, posterior tibial and peritoneal artery are patent with no occlusion there. So that makes the case a lot more approachable. Here, even in that case, I thought I would have to get dual access to try to reconstruct that trifurcation and preserve flow to each of the vessels. But you can see here I got dual dorsalis pedis and posterior tubular retrograde access, and injecting there, you can see that, again, much more patent lumen than we would have suspected. And was able to basically get dual access and reconstruct the bifurcation here. And basically you can see got a great result down to the foot. And basically the patient had refused amputation of those toes, and surprisingly his toes, which were gangrenous, actually improved significantly, and 2 years later, his toes are still on. Another example of hibernating lumen, a 66-year-old female with history of smoking, diabetes, coronary artery disease. She's very active. Her bicycle is her main form of transport. She has a left great toe cat bite, which has not been healing for 2 months. She came to my clinic looking like that. So basically, approaching this case, angiography demonstrated that the SFA was again occluded. There's a focal reconstitution here at the adductor canal, and then it occludes again and comes back to reconstitute the tibial vessels separately. Here, it looks like there may be an intact pedal loop, but in reality, it's not. This is a collateral pathway, and the pedal loop should be down here, so the pedal loop is actually closed. So again, a daunting case with multiple, long segment occlusions. So given the apparent separate occlusion of all 3 tibial vessels, I again chose a retrograde approach to try to reconstitute the bifurcations. You can see here on injection, again, what we thought was complete occlusion of this trifurcation is actually patent. So again, multiple reasons to try these cases, because they actually, a lot of times the lumen is just hibernating. So was able to traverse the occluded popliteal and SFA retrograde from that axis, and then was subintimal, unfortunately. You can see here the contrast injected from the common femoral sheath above is showing that here's the true lumen, and I'm basically subintimal here. So what do you do when you cannot enter the true lumen? This is extremely important to have a bunch of techniques in your armamentarium. So I find the most cheapest and fast way to kind of re-enter the new lumen, or re-enter the true lumen, is to try the CART technique, which is controlled antegrade retrograde traversal. It's a coronary technique from coronary literature, and basically you use a balloon to rupture the intimal flap and connect these lumens once you're in 2 different subintimal planes. And you can do that from either direction, from femoral axis or tibial axis. And if that doesn't work, sometimes you try 2 balloons, and that basically can rupture that intima and connect the 2 planes. You're really just trying to connect the 2 planes. If all else fails, you can also try facilitated reentry, puncturing a balloon from above with like an outback catheter. As we do these in chronic venous occlusions, you can definitely do it in tibial vessels also. I find the most useful technique that I've used is a gun sight technique, which you may be familiar with. A lot of people may be familiar with gun sight tips, but something that interventional radiologists are very familiar with for the most part. Using 2 micro snares, you position them overlapping within the subintimal planes, overlie them, and use a micropuncture needle to puncture through both, and then pass a hydrophilic wire. Usually I use actually a glide wire advantage or a gold tip glide wire. I actually use a gold tip glide wire for the most part. And then you pull basically the 2 wires through, externalizing them from both access points so that you have through and through access connecting the planes. And this is honestly almost cannot fail. This proves that you can really cross most lesions, honestly. And here's just an example of that in a tibial vessel. So you can see the needle coming through both snares. So for this case, I was subintimal from retrograde access. So I used the reverse CART technique. It easily opened up the subintimal plane into the true lumen and was able to snare the wire and externalize and head through and through access. Then, revascularize using balloon angioplasty, stenting as needed. You can see those pictures there. Was able to get great above the knee revascularization. And here, after revascularizing, there's 3 vessel runoff to the foot. So I didn't even need to honestly open up the tibials because they were already open. Again, hibernating lumen. You can see in the foot, though, the pedal-plantar loop is still out with that collateral pathway giving dominant flow. So our podiatrists often use indocyanine green immunofluorescence to assess intraoperatively whether a patient has enough blood flow to heal a wound. And they did use this, and they showed that basically the foot was still not getting enough blood flow to the toe. So they wanted me to open more plantar circulation. So again, this hibernating lumen concept does not just apply to the supramalleolar vessels. It also applies to the pedal vessels. So here you can see I got down into the distal posterior tibial artery. You can see there's a flush occlusion, or not flush occlusion, but there's an occlusion of the common plantar going into the lateral plantar and the dorsalis pedis. And basically, this actually consisted of multiple small occlusions rather than a gigantic long occlusion. It was multiple small occlusions, which was able to get through and actually relatively easily and balloon across the pedal loop. You can see here a wire across, and ultimately was able to get great flow. And now you can see, this is why knowing the pedal vascular anatomy is extremely important, where you can kind of look at this and confuse it for a patent pedal loop, but obviously it wasn't. You can see here. So she basically had a toe amputation, and 3 months later, she's biking around. Actually, even up until a year later now, she's biking around Key West, which is where she lives, fully functional. Flush occlusion is represented a unique challenge. So this is a case of that. A 72-year-old female ex-smoker, diabetes, presented with dorsal foot wound. You can see that nasty-looking foot wound on the dorsal aspect of her foot. Very scared of amputation. She had a prior intervention in an outside hospital. So this is an injection from above, and this is basically the posterior tibial peroneal trunk. There's a flush occlusion of the anterior tibial artery. They had placed a stent over the origin, so there was no real way to identify where that was. And you can see, honestly, in her posterior circulation, she has great flow to the plantar aspect of the foot through the posterior tibial, but literally zero flow to the area of the wound. And that's the real problem. We have to get the dorsalis pedis open somehow. And the stent was jailing the AT origin. So I couldn't find the origin from above. So basically chose to come through the pedal plantar loop, you can see here, and have a set of wires and things that you're comfortable with kind of coming through the pedal plantar loop. I usually use an 014 command wire and usually a CXI catheter, 014 or 018 support catheter. Sometimes if those catheters are too big to kind of cross lesions, I will use a teleport catheter, which is made by CSI. It's a coronary catheter. I don't know why this is kind of messing up here, but you saw my wire kind of traverse that pedal plantar loop relatively easily. And you can see here just passing up farther up into the retrograde into the anterior tibial artery through the pedal plantar loop. So basically I was able to reach the ATA origin around the pedal plantar loop. I had actually tried to puncture the dorsalis pedis retrograde, but it was occluded completely and I couldn't get in. So I used my wire as a marker at the tip of that AT origin. I knew that I wouldn't have enough length to get around with a balloon because of just the length and the lack of pushability across the pedal plantar loop. So kind of using that as a target. One thing I've seen people at Link do is cut a MPA catheter into a nice shape. And so that can kind of give you something that you can approach flush occlusions with. So here's an example. MPA catheter is cut, basically pushing it up against that flush occlusion coming through the stent interstices, and able to wire that relatively easily. And got down into the foot, basically ballooned across the interstices of the stent to open it up, and performed Coulot technique, which is a way of constructing bifurcations that was designed for tibial or coronary vessels with overlapping drug-eluting stents to kind of preserve that bifurcation there, and then balloon down into the dorsalis pedis. And you can see was able to really reconstruct that bifurcation quite well. And you can see great flow now down into the foot with a little bit of wound blush there. So dissections. So dissections are something that I think we haven't really found a great way to deal with in the tibials. We don't have completely dedicated tibial stents quite out on the market yet. And there's been multiple classification schemes for people have designed to try to find which dissections you can leave alone and which dissections you have to stent we're using coronary drug-eluting stents for the most part in the legs, and there's a limited space, obviously, that you can use them in more superiorly. Inferiorly, you're always worried about crushing. So we need to find a way to really look at these dissections and choose what is appropriate to treat them. One major classification system is the National Heart and Lung and Blood Institute class. And basically they found that at class C or greater dissections, there's a stepwise significant increase rate in restenosis and TLR rates. And so they found that dissections comprising greater than 1/3 of the lumen and lung dissections were the highest risk. So you can see a chart right here showing those. However, I really found that angiography, again, is just a limited way of looking at things, and IVUS is really necessary and is really the next step, I think, in the future of classifying dissections and stenoses. Nick Shamas has done a bunch of studies looking at IVUS, not only in the coronary literature, but also the tibials. And he's found that angiography underestimates vessel size by around 25%. So we're undersizing stents, we're undersizing balloons, and honestly, that may be affecting our limb salvage rates. You can see an example here. Basically, the angiography measured it at 3 millimeters, IVUS 5.25 millimeters of this TP trunk lesion. Also, he found in his studies that IVUS reveals around four times the number of dissections. And the severity of the dissection is actually shown. So you can see in this example, TP trunk looks great on angiography, but on IVUS, you can see there's a pretty significant dissection. So it remains to be kind of quantified which dissections on IVUS actually are the worst and which can be left alone. But here's an example: 72-year-old male with history of fempop bypass graft. He came in with it occluded. He had 24 hours of lysis. We usually drop a lysis catheter and check the next day to see what was the culprit lesion that caused the bypass to go down. And you can see here he has dissections, not sure exactly why, but of his popliteal and going down into his posterior tibial artery, which were likely the cause of his fempop bypass graft going down. So I don't know what you guys would do, but I usually don't like to stent the popliteal. I mean, I really want to avoid that. It's a bypass target. If I could preserve that, I think it's a lot better. This guy was very functional, walked all day with his grandkids, and I worry about placing stents across the popliteal. So after prolonged balloon angioplasty, you can see on the left-hand image, it looks pretty good. I mean, there is a dissection there, but it looks like it's not flow limiting. But then if you run IVUS through there, I could see that the dissection is a lot worse than I thought, and it's basically 360 degrees around the lumen, and it's pretty long. However, I chose not to stent that. I chose just to leave it and see how he did, because I really didn't want to stent. However, again, as expected, he returned with an occluded bypass 1 month later. You can see his flush occlusion of the, not flush, but there's an occlusion of the SFA, bypasses out, it reconstitutes at the popliteal. Once I went across, dropped this lysis catheter. And after 24 hours of lysis, again, I see the culprit is the dissections. Really have no choice here but to treat. But I could not cross him from antegrade direction. I kept getting into a subintimal plane in these dissection flaps. So to reconstruct this, got dual dorsalis pedis and posterior tibial artery access, ballooned, had to stent, unfortunately, but you can see he was able to reconstruct that bifurcation, and he has great flow to the foot, and he's now doing quite well. So another thing is, we're able to cross most lesions now. We got into those techniques of the gun sight, but we're kind of reaching the limits of technology for this disease state. You can see here's one technique we use quite often to cross lesions. It's called the Janali technique, devised by Jihad Mustafa, where something like a V18 wire is folded along its hydrophilic tip, and at the point where the stiff part comes into the more soft part, and basically you spin the wire and the device or the support catheter to create this kind of screw motion. And this is very useful, honestly. It gets through most occlusions. It just kind of flies through. Even if it goes into a subintimal plane, it actually re-enters quite well because of the stiffness of the whole system. And honestly, it's proved extremely useful in getting through really tough occlusions. However, the wire is really not meant to be bent like that. So a lot of the time the wire will fracture off and you have to find a way to remove it. We're dealing with these very complex lesions, and there's just not the durability of equipment out there is just not up to par right now. It's a call to industry to kind of improve that. And if you lose a piece of equipment within someone, it's in Florida, at least, it's a foreign body sentinel event and has to be notified to the state. So it's important to know kind of your bailout strategies for this. We've had, because we cross a lot of different lesions, we've had a lot of foreign bodies that we've had to get out. There's certain locations which I've listed here, which are extremely prone to having problems with device fracture. But there's a whole series of devices that we can use to remove these. And here's one example, a micro snare from pedal loop snaring the fractured V18 wire tip. You can see these other devices here, which are really helpful to have in the lab. You should have at least one, I guess. Here's just another example of a huge fractured wire being retrieved from the tibial vessel. The Cook vascular retrieval forceps, also extremely useful. We were able to snare this wire fragment out using those. So, we're able to cross most lesions. We're able to revascularize most patients. So who is the no option CLI patient? So if we look at the Basel trial, an audit of the Basel trial sites, they found that 50% of all CLI patients were considered not revascularizable by either surgery or angioplasty, 50%, and they were treated conservatively. So, I think that really the no option patient changes through time, obviously. We lack a consensus of who the no option CLI patient is now, but it really changes based on the available techniques. I think most of these patients may have been revascularizable at this point. So I think right now, currently what we're dealing with, for me, the no option patient really is a patient who has complete luminal obliteration by calcium. These can be extremely tough to treat. You can cross these lesions, but once you cross, you may not be able to get your vessel open because of the calcium. So the white stop sign is something, again, described by Jihad Mustafa on ultrasound, where there's complete luminal obliteration by calcium. So you can see it on these images here. So issues we have, in addition to inability to cross because there's no microchannels and the wires directed into the extravascular space, luminal gain is very hard to achieve. So poor stent deployment and complete recoil of the vessel is very common. So all your work can be in vain. So people have developed techniques to get through this. The Pierce technique was developed by Ichihashi, or at least described by him in the literature. And it's when you have these supremely calcified lesions, you're able to cross with a wire, but it's so calcified you can't get your device across, you can't get your balloon to expand. They actually take an external needle and puncture the calcium externally at the point of that where you can't cross, rotate the needle to try to fracture the calcium. And this has worked for me in a couple of occasions. It can lead to little perforations though, which you'll have to use angioplasty to stop. Here's just another example of that. So the microvasculature is another thing that can determine who a no option patient is. So Ferrarisi in these articles recently has described BAD versus SAD, and we'll get into that right here. So BAD is big artery disease. So occlusions of the macroscopic arteries, dorsalis pedis, the main arteries, tibial vessels, the lateral medial plantar. This is really a transmission failure. It's something that we can open these passageways up so we can improve the transmission of blood. And I think these are patients who we can revascularize. As opposed to SAD patients or small artery disease patients. These are usually end-stage renal disease, severe diabetics who have disease not just in the pedal plantar loop, but in the smaller blood vessels going to the arch, the metatarsals, calcaneal or digital branches. So this is distribution failure. And really, we don't have the equipment right now to open up these types of arteries. They're just too small. So even if we reestablish pedal-plantar loop flow in these patients, their outcomes are just not going to be as good because there's no they're not able to distribute the blood to the foot. This is just a study where they examined around 2,000 limbs of patients with CLI, and they saw that having SAD increases your risk of having critical limb ischemia significantly. You can see with no small artery disease, the odds ratio for having critical limb ischemia is much less than the patients with small artery disease. Here's an example of a no-option patient, 72-year-old female, end-stage renal disease, diabetes, prior left BK, vasculopath. She had a recent TMA, which was becoming necrotic, and so she was sent to me for vascularization. You can see here, she has what's the start of some tibial vasculature, but then it basically occludes down at her lower ankle, and then she really has a desert foot. This is the angiogram of her foot. So I was able to easily, or somewhat easily, get around the pedal-plantar loop, balloon that. You can see these images here, reconstruct her vasculature, and you can see I had really robust flow through the pedal-plantar loop. However, you'll notice on this image, there is great flow through the pedal-plantar loop, but there's really no small vessels that are opacifying. So my thought with this was I was very worried that the pedal-plantar loop was going to go down because there's just nowhere for that blood to go. So, her foot was amputated further after that revascularization attempts. Unfortunately, it became necrotic, and kind of as expected, she eventually went on to get a BKA because of that. So, this patient, there's just no way to revascularize those vessels right now using conventional techniques unless we think of DVA. So DVA, maybe that is the real first step for these patients with small artery disease, honestly, as we kind of get out there, and there's more and more data being described for this. Another option for small artery disease, one thing that we're doing at our institution is a non-surgical treatment in general. We're trying chelation therapy. Maybe this will help. I'm not sure yet. The data is still out there, but DVA and chelation really seem to be pushing us. People are at least thinking of ways to treat small artery disease, which I think is the current no-option patient for me. This is our multidisciplinary vascular team. If you have any questions, you can call us anytime, and we'd love to talk to you. We'd love to have medical students rotate also. Thank you.